Hello, my name is Frazier Fortenberry, and I am a solo practitioner practicing general urology for the last 27 years in Charlottesville, Virginia. My interests include numerous urological problems, but certainly BPH-related LUTS is a primary interest of mine. I have been performing surgical procedures for BPH management since I completed residency in 1990. These have included unipolar TURP, unipolar transurethral vaporization, various thermotherapy procedures including tuna radiofrequency, indigo laser, and microwave thermotherapy. Then around 2001, I began performing bipolar TURP and later bipolar button vaporization. I have also had a great deal of experience with green light PVP. My dissatisfaction with all of these procedures has been to try to find a minimally invasive alternative that can also produce excellent and durable outcomes. Before laser enucleation, I felt the best opportunity to achieve that goal was bipolar TURP. However, this operation could be quite challenging because of hematuria and bleeding during the procedure, and sometimes required overnight hospitalization and further support for management of the hematuria. I became interested in laser enucleation reading about HOLEP over a decade ago. For me, the challenge was to access the equipment and also to get the proper training in order to perform this procedure. The conflict for a solo practitioner without fellowship training was first trying to find a vendor willing to bring the technology in, which was quite difficult, and also eventually persuading the hospital to support my effort in purchasing the necessary equipment to perform the procedure. Of course, I was aware of the steep learning curve, partly related to bleeding during the enucleation procedure. In 2011, I began to modify my button vaporization procedure toward a bipolar button partial enucleation followed by loop resection of the attached tissue. Later, I had the privilege of observing 3 HOLEP procedures performed by Dr. Lingeman and his fellows at Indiana University. I tried my first HOLEP procedure in late 2011, and unfortunately the experience was less than optimal. I had to complete this procedure with a rescue TURP. So I became disillusioned with the prospects of ever performing laser enucleation while continuing to work with this partial enucleation technique. In about 2013, I was approached by Daryl Shires representing Richard Wolf and collaborating with Convergent Laser about starting to perform this enucleation procedure using the 1470 nanometer convergent laser fiber along with using the Richard Wolf resectoscope and morcellator. I started performing laser enucleation in September 2013 independently. Within 6 months, I took the time to observe 3 additional cases in Philadelphia performed by Dr. Akhil Das. Since then, I have performed approximately 150 laser enucleation cases using this equipment and technique. This has been a very rewarding experience and has dramatically impacted my practice. What I find remarkable is the degree of hemostasis provided by this convergent laser technology, and certainly it was thrilling to be able to transfer my already established TURP skills intuitively using this Wolf laser resectoscope equipment. Obviously, there remained a great deal of learning over time, but even at the beginning, I was able to complete the laser procedures without having to resort to rescue TURP. In fact, I have never utilized TURP during one of these cases. Of the 150 cases, there were 2 cases early in my procedures whereupon I could not complete the morcellation because of the hematuria. I simply inserted the catheter and brought the patient back in both cases the following week and completed the morcellation without any difficulty. Of course, I have improved my technique and efficiency over time and with experience, but my perspective is that using this particular equipment, including the convergent laser, one can learn this procedure and complete the procedure successfully early in the experience. My impression is that the amount of hematuria both during and after the procedure compared to homium is greatly reduced. Most of my laser enucleation procedures, and this includes several BPH resected volumes of 75 to 100 gram, have been discharged the same day of the procedure with indwelling catheter for outpatient management. I have performed this procedure on numerous occasions on patients remaining on baby aspirin for cardioprotection, and also I have performed this procedure on patients anticoagulated on Coumadin. The outcomes are gratifying because we eliminate all of the BPH tissue. I can reassure the patient that he will not need a repeat procedure in the future because all of the tissue has been resected. Furthermore, an added benefit is that many of these patients with BPH-related PSA elevation will see their PSA levels in the future greatly reduced, which greatly simplifies their follow-up in the future. Postoperative hematuria and dysuria are also greatly reduced with this technique compared to all previous techniques. I hope that these comments will reassure and encourage you to consider bringing this very gratifying, valuable procedure to your practice. Thank you.